Hi, good morning, everyone. Welcome to our CMAAO International Weekly Meeting. Today is 21st September, 9:30 a.m. Indian Standard Time. Uh, we have a very important topic today. We're talking about Thoracic Oncology. To talk about this, we have Padma Shri Dr. Ramakant Krishnaji Deshpande. Padma Shri Dr. Ramakant Krishnaji Deshpande is one of the Indian leading oncologists and a pioneer in cancer treatment. He's the executive chairman for Asia Institute of Oncology in Mumbai. He has contributed immensely in the field of thoracic surgery and oncology over the past 4 decades. Recognized with the prestigious Padma Shri Award by the Government of India, it's the first highest civilian award. Dr. Deshpande is celebrated for his innovation techniques in cancer care and his dedication to advanced medical practices. His work has improved the living for countless patients, making it as a prominent figure in healthcare industry. Sir, I invite you for enlightening us for this session.
Hello, Saurabh. Hello, everybody. Thank you very much for giving me this opportunity of sharing this platform for an interaction today. And I welcome all of you. Today's topic is essentially the status of minimally invasive surgery in thoracic oncology and where we are going in future. There are many ways of surgeries, and every time that we operate, the surgeons, the scientists keep thinking as to how to actually improve the whole fate of the patients. And that is the reason why most of the research keeps coming up. If I can share my... Okay. Okay. The status and future of minimally invasive surgery in thoracic oncology. What does minimally invasive surgery in oncology mean? In chest, obviously, thoracic oncology means oncologic surgery, cancer surgery, which is related to the chest. And minimally invasive thoracic surgery is a way of performing the surgery in the chest through small incisions without making very large cuts or incisions in the body, and does not require spreading apart from the ribs. Surgeons use a camera and instruments to get to the lung through small incision in between the ribs. When we operate actually and try to get into the chest for any kind of surgery, be it cardiac, be it for the lung, be it for the thymus gland, normally you are entering into a box. And how do you open this box? Either you split the sternum vertically, a vertical incision, or you go in between the ribs and spread the ribs using instruments. And remember, the ribs have multiple nerves under them. So there is a lot of pain as soon as the patient wakes up and for a long period to come. So we'll discuss this whole thing in evolution in techniques, indications and results, technological advances, and training and education, and the future directions. Why minimally invasive surgery in thoracic? Video-assisted thoracic surgery, or VATS as it is called, is widely used now for lung resections, biopsies, pleural disease management, etc. It reduces the pain because we don't really use a spreader of the ribs. There's a quicker recovery and shorter hospital stays compared to open surgery. Then you extend this particular thing using a machine called Robo, and that's increasingly complex surgery, but it's utilized for complex thoracic procedures, systems, etc., provides enhanced dexterity because the instruments can actually be manipulated in 8 different ways. There is a 3-dimensional visualization, which is not possible in case of video-assisted thoracic surgery unless you use a 3D camera, and there is a definite improved precision in this surgery. The indications commonly are applied for lung cancer, esophageal cancer, mediastinal tumors, etc. But the indications for minimally invasive surgery continue to expand based on the tumor size, location, and the disease status. The outcomes, yes. I mean, obviously, if you're choosing one over the other, it leads to lower morbidity and mortality rates, faster recovery, improved quality of life, long-term survival rates should be comparable. This is absolutely essential than traditional open surgeries for early disease. Most solid tumors in thorax, be it lung, esophagus, or thymus, or a tumor in mediastinum, have surgery as the definitive answer. Surgery continues to be the most effective curative kind of a treatment, which means that you need to get into the chest to remove that particular tumor or the organ or whatever that you are planning to remove. Normally, we would do exploratory thoracotomy, median sternotomy, which is a well-established solution for this, except for its lasting problems of long incisions with post-thoracotomy pains and at times very ugly scars. Uh, uh, in 1992, Lewis et al., after a series of 100 laparoscopic cholecystectomy, published a report of 3 lobectomies with hilar vascular dissection. Mind you, you're actually operating in a box without putting your hand in the box, with only the help of the telescopes and instruments, and with a potential that you may damage one of the instruments and one of the vessels, if it happens, then patient will be dead within a few minutes. So that these are the kind of risks that surgeons need to take and to become experts in this, so that with a smaller thoracotomy with use of camera, we should be able to help the patient with difficult to see areas. Slowly and steadily, a hybrid technique of combination of small incisions but use of camera was evolved, and it's still practiced in some center with small rib spreaders being used. Then the CALGB group defined VATS as 2 5mm ports and 1 4 cm utility port for the first time without use of rib spreader later, with first report of such cases in 2007. Actually, laparoscopy started coming back into vogue in 1980s, and by the time thoracoscopy came in, it was quite an experience kind of a line of surgery in the abdomen. Thoracic area started a little later. But when did actually video assisted or telescopic visualization of the chest really start? This started more than 100 years back, which was initiated by a pulmonary physician called Jacobius in 1915, who used it primarily as a diagnostic and a therapeutic tool for adhesiolysis in tuberculosis till 1950, when streptomycin was discovered, and that effectively paid for this investigation and treatment. But in the meantime, Swerenega et al., Brandt and Bully published much literature in 1970 about thoracoscopy, its complications, its benefits, etc. In 1990s, with the advent of multiple endoscopes with a lot of benefits and instrumentation, video-assisted thoracoscopy started dividing into medical and surgical thoracoscopy. Medical thoracoscopy is a minimally invasive procedure that allows access to the pleural space through telescope by a combination of instruments for diagnostic or therapeutic procedures. We can use this for pleural biopsies, for diagnostic of dilemmatic pleural effusion, adhesiotomy, minor decortication, pleurodesis, etc., using multiple agents like surgical talc, povidone iodine, or several chemotherapeutic agents to promote pleural adhesions, excision of emphysematous bulla. So today, by and large, video-assisted thoracoscopy, as it stands today, is divided into either it's a surgical VATS or a medical VATS. I mean, I'm sorry, the top has been exchanged actually. The medical VATS is performed by the pulmonary physician. It's done in daycare rooms under local anesthesia, under spontaneous breathing. Usually a port is a single, whereas the surgical wards, a general anesthesia or cervical epidural with sedation is required. A double lumen tube with one lung deflated is required. The ports could be either a single port or a multiple port, and lot of procedures including bulectomy, adhesiotomy, resection of pulmonary nodule, pericardial window, lobectomies, all kinds of lung resection, esophageal resections, etc., can be undertaken. So the implication of this particular chart is a medical VATS, that is a physician, an MD physician can do only certain things and not beyond that. And if he tries that, then it will become medical negligence. So that is what is very, very important to understand. Over a period of time, with evolution of long instruments which actually open within the chest and not at the chest wall level, you can see here that the ratchet of this particular instrument is very, very deep so that it will open only inside. And that's why you can use special VATS instruments, and that's how VATS surgery is really possible. We have what we call as a hybrid VATS, that is use a small thoracotomy where you are actually running a combination of actually watching, maybe using a finger with use of telescope, but this way of operating still persists, and people use the telescope just to identify those areas which are very hard to be seen by only an eye. This is very important for us to realize, particularly in a country like India, where uh, to keep the incisions small, surgeons still do hybrid VATS. A retrospective propensity score matched analysis comparing hybrid VATS, 178 patients, to pure thoracoscopic, which means that you just put only the ports and you don't really use any finger, any touch incision or anything, found similar short and long-term outcomes, including 5-year survival statistics in predominantly stage 1A patients. Operative time, of course, with hybrid VATS was a little shorter because you could, it was a combination of an open surgery and minimally invasive surgery. The mini thoracotomy of hybrid VATS may improve the ease of the complex procedures, such as sleeve resections that are otherwise often challenging with a pure thoracoscopic approach, particularly if the surgeon has not had a long experience or has not been mentored appropriately. While we cannot suggest the superiority of hybrid VATS over open or pure VATS, hybrid VATS is both feasible and relatively safe, and is, as I mentioned, practiced at many, many locations. In fact, if you strictly analyze, many of the so-called VATS esophagectomies may not really qualify to be called as pure VATS at all. So currently, the video-assisted thoracoscopic surgeries are the hybrid VATS, the pure multiportal VATS, versus the single portal VATS, and there is a subxiphoid approach which actually completely bypasses the intercostal location altogether. Coming to the single port VATS, rather than putting multiple incisions, why not actually put only one incision, was a thought which came to the mind of many. And a study comparing uniportal and multiportal VATS, including a meta-analysis, demonstrated a statistically significant reduction in the overall rate of complications, length of hospitalization, and duration of postoperative drainage for patients who underwent uniportal VATS lobectomy. Mind you, the multiple incisions add to the possibility of drainage actually going up, and that is why a uniportal VATS lobectomy or any kind of a procedure inside will actually help reduce the morbidity. In addition, there was no significant difference between the two treatment groups with regards to mortality, operative time, perioperative blood loss, and rate of conversion to open thoracotomy. So you're doing just a single large incision, not very large, but just to put multiple instruments through that, and you are doing the same kind of a surgery. Other comparative studies found no increase in intraoperative blood loss, postoperative morbidity with uniport VATS as compared to conventional VATS. One study also found uniport VATS anatomical resection to be feasible, equally safe, and of comparable oncologic efficacy to biportal VATS. In the only comparative study to look at survival, Han et al. Found uniportal VATS to be non-inferior to multiport VATS throughout 2006 to 2015. Today, most high-volume surgical centers practice either VATS or robotic-assisted thoracic surgery for all kinds of lung surgeries as well as esophageal surgeries. And the ones with special experience have progressed to single portal VATS or RATS. I would say that almost about any high-volume surgical center has 60 to 70% chance that it will be offering this surgery with minimally accessible, minimally invasive kind of surgery. Now, how do we compare VATS versus robotic? Compared with video-assisted thoracoscopic surgery, robotic surgery offers several advantages, including a three-dimensional high-definition visualization and improved instrumentation via wristed instruments offering 7 degrees of motion. This is extremely important. Normally, in case as I showed you, the wax instruments are fairly long. You have just one level of articulation, whereas the robotic has almost about 7 degrees of motion because it can actually bend at various points which are predetermined. Now, these advantages address some of the limitations of WATS, including rigid instrumentation and two-dimensional imaging. With RATs, the camera and the instruments are controlled by a seated surgeon from a console that is outside of the sterile field. So the level of comfort is definitely far superior for a surgeon. And if a comfortable surgeon is likely to deliver a more comfortable result to the patient. RATS enables safe and careful dissection throughout its superior instrumentation related to video-assisted thoracoscopic surgery, but a well-experienced surgeon actually overcomes this particular disadvantage by putting in a little more effort than the others. This is important, especially for nodal dissection, in order to accurately stage cancer as well as large or central tumors, which may be next to major mediastinal structures such as the heart and aorta. It also permits much easier suturing for sleeve resection. Unlike the RATs, in case of VATs, the sleeve resection anastomosis is slightly more difficult. So RATs has been employed successfully for almost all types of lung cancer surgery, mediastinal surgery, esophageal surgery, even including chest wall excisions have been possible now. Uh, they may have a slightly higher risk for conversion to open surgery, including pneumonectomy, bronchoplasty, chest wall resection, prior radiation, and central kind of tumors. Now, how did all this become possible? How did endoscopic surgery become possible at all? Then the advances in instrumentation was something which actually contributed a lot to all this. And without these four things, what you're seeing here, it would just not have been possible to go ahead with these kind of advances. And that's why you see this is a stapler being used on one of the veins. This is a stapler being used on the lung itself. This is a harmonic scalpel, which is actually cutting part of the lung and opening up the fissure. And this is a clip, a liga clip, a vascular clip, which actually will close down the vessel. Without these, actually, it's extremely difficult to go ahead with any kind of a conservative surgery or with minimally invasive surgery, etc. The current status is finally few of the surgeons got together and then they said that why not actually minimize the pain problem altogether. So they, Liu et al. Published the first such report in as recent as 2014 with an aim of avoiding pain related to intercostal nerve injury. The sub-xiphoid approaches are safe and feasible for early stage lung cancer with significant decrease in postoperative incision pain. Uniquely, a single sub-xiphoid incision can be used to treat bilaterally with a large kind of a port where three instruments are actually going, one camera and two manipulative instruments. However, sub-xiphoid approaches limit visualization even more than the transthoracic approach, the multiple ones, what you can see there. You can see here that in this particular patient, there are three ports which are being used for bilateral lung surgery, and it can be done fairly comfortably. You can see here, this is the thoracoscopic, these are the incisions. There are three instruments, and one is a working port for removal of a mediastinal thymoma. This is from the right side, and this is from the left side. You can see here that the complete thymus has been completely removed. There is a thymoma inside, and you actually, what you do is you completely eccentric it. Now, this is the tail of the thymic gland in the neck, which goes into the neck. And the complete eccentricity of the anterior compartment is always done because you will find in some patients that the fat tissue, which is away from even the thymic tumor, may harbor some amount of normal thymus, and that may become tumorous later on. The further advance in case of minimally invasive is microlobectomy. You start using 5 mm working port. The site of port, this thing is exactly the same, but you are using smaller. You can see here that the stapler is like a micro cutter. The incisions are barely seen, or in sub-xiphoid. Even the micro cutter, this is a very small stapler, but it's good enough for a lung resection. So these are all the progresses what we can actually see that can be done in a minimally invasive surgery. Then we come to the single port. You can see here that this is a single port with an isolator, and you are actually putting the camera here and three instruments inside. The idea is very, very clear that your insertion is very, very close to the hilum. Since this is the most crucial part, this is where you actually put an ideal port with good approach to the hilar vessels and wide angle for the instruments. We should not be very low or very high for putting the port. So identification based on your either even a plain X-ray or even a CT scan will actually help. So this is extremely important to understand. What are the other things that we can actually do with video-assisted thoracoscopy? This is a bronchogenic cyst. You can see here from the esophagus, and it has been completely excised. Normally, this patient would have needed a 6 to 8 inches of thoracotomy, whereas this is only a 4 centimeter incision, help to take this particular abnormality completely out, eliminating all the pains, etc. There is a posterior mediastinal neurolemoma. You can see here with a combination of an energy device like harmonic scalpel or a bipolar, you can actually excise this thing completely. You can see that you can take out this particular thing very, very comfortably rather than making a very, very large incision. The same thing can extend, just now we talked about the thymus, we talked about the lung to some extent. The minimally invasive esophagectomy approach we see that there is no difference in the rate of margin positivity or the number of lymph nodes retrieved. There is no difference in time to recurrence or median 3 or 5 year survival. And we can do not only total esophagectomy, but even Ivor Lewis. The randomized controlled time trial compared the minimally invasive route to the fully open route for 3 feet esophagectomy is indicated for cancer of the esophagus and showed a significant decrease in respiratory infections and length of hospitalization. At the same time, the number of lymph nodes, which is thought to be absolutely essential to compare survival statistics, they were almost the same. There was no difference in the two groups. So it means that you can do the same surgery by a different method, but equally effectively, and reducing any kind of potential problems immediately or in the later time. You can actually do multiple combinations there. You can do a laparoscopy plus thoracoscopy with neck anastomosis, which is purely minimally invasive, or you can do a hybrid one, where you can use laparoscopy for abdominal surgery, a thoracotomy for Ivor Lewis, or this was the Miro trial, which actually showed that the results were almost identical. A decrease in the rate of serious postoperative complication at 30 days was shown to be reduced from 64% to 36% in the laparoscopy group. In addition, a decrease in pulmonary complications at 30 days of 30 to 18% was demonstrated in the laparoscopy group also. So the advantages of minimally invasive surgery in case of esophageal surgery includes smaller incisions, lesser blood loss, fewer postoperative complications, shorter ICU and hospital stay, and better preservation of postoperative pulmonary function. Very relevant in all those patients who are more than 70 years of age, and there are a good number of these patients where we do preventive tracheostomy. Those kind of interventions can be almost be given up. There are certain areas of uncertainty, like minimally invasive procedure, adequacy of the margins, etc. What happens is if you have the entire esophagus is got a field cancerization, then because you're doing it endoscopically, sometimes you don't have the tactical feel, and that is why you don't know how far to go. The extent of lymph nodes also, because it's a visual thing. It's difficult, but if you use spectroscopy with radioactive isotopes, then probably I think this part can be taken care of. And secondly, safety of is minimally invasive esophagectomy in patients who have undergone preoperative radiation therapy, particularly in middle third, is a tricky situation, because sometimes you can land up damaging maybe the posterior wall of the trachea or the bronchus, or even sometimes, very rarely, disastrously so, even the wall of the aorta. Long-term oncology outcomes, by and large, today, I think that is established that doing minimally invasive surgery does not really damage your surgical results. Now we come to the lung. Now we know that a lung has 3 lobes on the right side, 2 lobes on the left side, totally 10 segments on the right, 9 segments on the left. The lesion could be either in the periphery or it could be in the hilum, etc. So the need for surgery is very clear. It could be a wedge resection in an exceptional kind of a situation where the person is maybe very, very old or very infirm. But classically, a minimum thing of segmentectomy, lobectomy, or a pneumonectomy is needed. When you're doing a conservative resection, the the uh, uh, excision done in the normal part of the lung should be actually equal to or more than the diameter of the disease, which means that if you are excising a 2 centimeter tumor in case of an upper lobe, then it means that you must have at least 2 centimeters normal lung all around it. Otherwise, your local recurrence will go through the roof, and it is just not desirable. If the lesion is in the center, then you will have to actually do a sleeve resection, taking an entire lobe out and then joining these particular 2 parts, which involves a demandingly accurate anastomosis, and that is exactly what we'll need to see. You can see here that the anastomosis has been done. So, to do all these kind of surgeries, apart from the video assisted, the robotic surgery evolution has come now over a period of last 20 years. Da Vinci robotic system, which was the first one to start, was developed from 1995 to 2000 and first approved for abdominal surgery in 2000. After collecting a little experience, today they have done more than 7 million procedures in case of thorax. The first use of a robotic system in performance of a lobectomy was done by a group in Pisa, Italy in 2001. They performed 5 lobectomies with 0 mortality. These lobectomies were performed by the first generation of the Da Vinci system, and the mean time for surgery was about 5 hours. What you're seeing here now is the Da Vinci Xi, which is almost the 4th generation machine. And now they have released the 5th generation machine also. Before this, we used to have large incisions like this and huge exposure. Now this patient has undergone a pneumonectomy. You can see here that everything is very clean, absolutely fine. But what comes with it is a huge incision in the chest, and that causes a lot of problem. When you do an R-block resection of a superior vena cava, because that's the only area which is actually involved, then that becomes a bit of a problem to do these kind of surgeries without a good access and visibility. This is another one where we have done a bronchovascular sleeve, which means that there's a vessel also involved, there's a bronchus also involved. You can see here that this is the upper lobectomy opening is there, and this has to be actually be anastomosis there. You can see here that this anastomosis is being completed here, and we have put a patch here onto the superior vena cava. So to do these kind of surgeries, you need to have a very clear-cut access to that particular area and a level of comfort which should be offered. And these things are slightly tricky with video-assisted thoracoscopic surgery, but slightly easier from the robotic kind of a surgery. Sarfolio et al. Performed a retrospective study to compare rats with propensity-matched control rib and nerve sparing thoracotomy. They found that patients with rats had a statistically significant reduction in perioperative morbidity, chest tube drainage, and hospital stay than those undergoing thoracotomy. Another single institution study compared consecutive anatomical lung resection by rats versus VATS over a 2-year period and found no difference between the two groups regarding operative time, number of nodes, blood loss, intensive care stay, length of stay, or mortality. However, the duration of narcotic usage after discharge and the time to return to usual activities was significantly shorter with robotic surgery. So now, how far have we come here? So while doing robotic surgery, the surgeon is comfortable. Having undergone robotic surgery, the patient is comfortable during and after surgery. One large study used the Canadian State Inpatient Database from 2008 to 2010 and compared 33,095 patients who underwent either an open lobectomy in case of 20,000 plus patients, VATS in 12,000 patients, and robotic in 430. In openly matched analysis, propensity matched analysis, RATS was associated with significant, markedly. Such huge numbers in comparison are there. Robotic are much smaller, but the robotic showed significantly reduction in mortality, length of stay, overall complication rates when compared with any open thoracotomy. They were also associated with reduced mortality, length of stay, and overall complication rates. Now, what are the various robotic systems which are available in India? Mind you, there are more than 10 to 12 robotic systems available based on which part of the human body you are operating. You have a robo for a knee, you have a robo for head and neck, you have a robo for spine, and so on and so forth. But in case of thorax, which is our topic, these are the common ones which are actually in our country and are working. The left one, what you see, is the granddaddy of all. That is the intuitive Da Vinci system. The central one is the Versailles system, which is from England. And the right one is our own Make in India mantra system, which is devised and manufactured in India itself. This is they differ. These systems differ one more thing is apart from, you can see here that this is one machine with 4 arms here. These are 4 pillars here, which are 4 are different arms, and this is something very similar. But the basic difference is here the vision gantry is you put the surgeon put the head inside here, doesn't really need to wear any specs or anything. All the adjustment which is done for 3-dimensional vision, the machine does itself. So the strain is slightly less. But here, actually, the surgeon is sitting here, and here this is there's a screen there, and he's using a 3D glasses like what we normally see for 3D films or something like that. So that does become a little bit of a strain initially, but over a period of time, we can actually get used to it. As far as other things are concerned, ability to manipulate the instruments, the harmonic scalpel, the scissors, the clips, etc. By and large, there is very little to choose between the various machines, except for the level of sophistication is slightly different. These are the robotic instruments you can see here that they can actually bend much more than the video-assisted thoracoscopic surgery here. You can see this. These are the robotic instruments. You also have robotic staplers. You also have robotic harmonic. And then, exactly like uniportal VATs, we have uniportal RATs also. So one port, and you can actually put in multiple instruments through that and go ahead and do the surgery. The instruments are obviously much smaller, finer, etc. But the same way they are manipulated, and we go ahead with the surgery. So these are the sites of entry for the the robotic esophagectomy. The open transthoracic esophagectomy for resectable esophageal cancer, randomly controlled trial, that is a robo trial, compared the open route with the totally minimally invasive robo-assisted route with manual cervical anastomosis. There were reduced respiratory complications, better and faster postoperative recovery, lymph node yield is identical, and long-term survival improvement was 18% better in robotic. Okay, so this is the robotic assisted thoracic surgery. You can see here that the surgery is progressing here. And this is the video-assisted thoracoscopic surgery. Remember one thing, no matter which method you use, whether it's open, video-assisted thoracoscopy or robotic surgery, one must always have a completely microscopic resection, which means that you are not justified in leaving part of the disease or any lymphatic disease inside the patient. If you do, then you can see here, there's a survival immediately drops. So this is the importance of R0 resection in case of all these kind of surgeries. And this is a fundamental principle. While trying to appear fashionable, while trying to appear to be helping the patient, never lose the sight that you are striving to achieve R0. Without an R0, nothing is really justified. What are the further now advances what you can actually do? You can use a navigational guided bronchoscope. What happens is when you have a very small peripheral lesion, quite often you can't really see it. If you're going to do a total video assisted thoracoscopic surgery or a robotic surgery, those lesions can't be seen. Now, how do you really excise those lesions? So what you can actually do is you can use a navigational guided bronchoscope like this, what is being seen here, go right up to the lesion, either put a coil there, okay, a cage or a coil, something which is radio opaque, or you inject a dye there, so that when you go inside the chest, you can actually identify that, yes, this is the abnormal area, and then you take the wedge out. So that is the best way to improve your results with a minimally invasive surgery. You could also do this particular thing using a special electromagnetic navigational bronchoscope here. As you can see here, that there's an electromagnetic spot here, which is being seen. And so that you can actually, the surgeon is going to take only that particular part out. This is video-assisted thoracoscopic lobectomy in progress. And this is a patient who had an anterior segment lesion in right upper lobe, for which no significant node in the lymph node. So we VATS right upper lobectomy with lymphadenectomy was done. And despite no enlarged node, we found that one lymph node was positive for metastasis. So it turned out to be a T1B N1M0. And this was the result of the first video-assisted thoracoscopic lobectomy in India, which was in October 2000 that we performed. Less than lobectomy, actually you can go ahead and do only a segmental resection or even a subsegmental resection. As I mentioned, the principle of excision remains the same, that the excision of normal tissue beyond the disease has to be equal to the diameter of the disease, and that is absolutely minimal. And how does a segmental resection compare to lobectomy in small size peripheral non-small cell lung cancer? The JCOG 802 trial, which is a phase 3 multi-center randomized controlled trial, showed that in 1100 patients of less than 2 centimeter lesions, actually the 5-year overall survival in lobectomy was 91%, and in segmentectomy was a comparable non-inferior 94%. Post-op FEV1 at 1 year was minus 12% in case of lobectomy and minus 8.5. The local recurrence, of course, was marginally higher, but the numbers were significant. So today, if you do a proper segmentectomy, that should be the standard surgical procedure instead of lobectomy. There are further advances actually that you can use image guided. For example, you can see here that this is a small kind of a lesion, and you can actually take this particular thing out. You will have your CT scan, MR scan, vascular studies, everything is mapped together. You can identify these vessels together, and you can take out only that particular portion. This is very relevant because nowadays our patient population of more than 50% is beyond the age of 65 years. So saving any kind of lung without compromising the radicality, without reducing the R0 status is extremely important. And if you can do a segmental resection, it is all the better. And if you can actually use an image-guided left You can see here that segment 10 excision is one of the difficult ones, and you can actually do that, pick up those vessels correctly. You need to go a little deeper into the lung, but it is perfectly possible with a little bit of a patience. And the benefit, you can see here, rather than having the 10 and 12 inches incision, you can have, this was one of the earlier cases. Now our incisions are barely about 4 centimeter, small this thing, and the port itself is used for putting intercostal tube. This is a robotic lung resection. You know, the number of ports will remain almost the same. The location also will remain almost the same, but the visibility is very nice. The manipulation is very nice, and you can go ahead and do everything that you can do, but in a far better way with robotic. The console surgeon's view during the left upper division, this thing, you can see here that this is a utility incision. These are the 3 ports which have been put. You can actually pick the vessel, whatever you want, and then you can actually clip it off, and then you can see here you can staple this particular thing off, and the procedure has been completed and removed. So this is the kind of a surgery that you can actually offer in a robotic surgery. The same robotic surgery can also be done with a single port. You can see here that there's a single port. It's a special machine. Single port machine is a special machine. These things are slightly different. You can see that the machine, the instruments also are much more mobile. They are different, but this actually is definitely a further progress and advantage in this thing. As I mentioned, you know, if there is a small lesion within the lung, how do we really do that? Then what we can do is we can do a dye localization and segmental resection. You can do the tying of the vessel. You can take out that particular tumor. You can see here that the conical excision here is actually taking out everything, making it sure that the healthy part of the lung is more than the diameter of the tumor. You can use a combination of inflation and deflation, which are technical requirements for excising that particular lung properly. What is the advances what are coming now? As screening for lung cancer is increasing, what is happening is smaller tumors or tumors within absolutely the lung tissue are becoming more and more common. So it's perfectly possible that your tumor is here and you land up excising here if you're not very careful or if you're not guided properly. So you can actually use artificial intelligence or holographic on-site imaging of lung and abnormality within using smart glasses. He is using smart glasses, you can see here, and there is a large amount of information which is being fed to him, and that is exactly how he's going to do a segmental resection. So holomedicine surgery, a 3-dimensional views for better localization of small peripheral lung lesions is something which is coming up very, very fast and absolutely is the need of the hour. With the help of 3D holograms, we can capture the complex vessel and organ anatomy of the specific patient much faster. In addition, we can overlay these images onto real patient and get a better spatial understanding of the tumor position. It simplifies anatomical orientation, planning, and improves communication within the surgeon and the interdisciplinary team, especially in complex surgeries. This allows us to operate much more easier. You can see here that there is a problem. Then you can actually plan the whole thing and you can remove that particular part very, very successfully, and the results will be excellent. So you are actually tailoring the requirement to the, so this is how the technique has progressed to technology. So to visualize a complex case with several tumors present, the holomedicine is used as a complementary tool along with conventional CT MRI imaging. So all these things are actually mixed together for an accurate tumor location, reduced recovery time, intuitive visualization, and understand one thing, you cannot plan for what you cannot really see. So you need to see that. So and that's how you make life possible. And is it really worth it? Is the robotic surgery worth it? There's enough data today. I've just picked up just one of the many papers of comparison of robotic assisted lobectomy with video assisted thoracic surgery of stage 2B and 3A non-small cell lung cancer. And you will find that from an oncological standpoint, the results confirm the complete resection rate is identical in both groups. Mediastinal lymphadenectomy is comparable with the two techniques, which means that the results will certainly be non-inferior. This is what is very important. Does it mean that we have reached perfection? No. We have many challenges in both minimally invasive thoracoscopic surgery as well as in robotic surgery. Mind you, not every hospital, even in the US, will be able to afford a robo. There are many hospitals which have multiple robots sitting side by side in their multiple theaters, and there are multiple hospitals which don't have even a single robo because of the cost consideration. Many more such hospitals exist in India. In a huge country like India, I don't think that even we have 100 robots also till date, whereas in the US, you have practically about 4,000 robots which are functioning at this particular time. Some of the challenges is, one is intraoperative visualization was a notable problem in the early era of minimally invasive surgery because of low definition optics and suboptimal lighting. The light was not adequate, the camera quality was not very good. Now, cameras are able to provide high definition images, and hospital can purchase minimally invasive surgery cameras with additional capabilities, including 3D video, near infrared spectroscopy, and integration with augmented reality surgical navigation system that I shown you just now. Cameras are no longer a limitation of MIS approaches, and with every addition, either the VAT system or the robotic system, they are showing improved kind of camera systems, and surgeons have begun using thoracoscope for challenging open cases also to improve visualization or lighting. Next one is in the instrumentation. Poor maneuverability. Mind you, your introduction point is one. You have a rigid instrument, so the maneuverability is obviously rigid. Inserted through rigid chest wall is problematic. The human hand can perform complex traction and counter traction maneuvers with tactile feedback. It's a gentle instrument. Human hand is a gentle instrument. These factors have proved to be difficult to replicate with current MIS instruments, even the robotic ones. Multiple thoracoscopy tools do provide some haptic feedback because you're actually seeing it, your hand is feeling it during wards. But it doesn't happen in the robotics. But surgeons have increasingly come to rely on visual clues. Here too, advances in MIS approaches have been applied to open surgery. Endoscopic stapling devices have become popular even during open operations due to their smaller profile and flexibility. Virtual haptic feedback is certainly under development. Robotic prototypes, particularly the Da Vinci 5, is supposed to have some kind of a measurement of force and translates it into a sense of touch at the console. Now, I have not used it, but I think only time is the answer. In the interim, parallel research is going to improve the types of visual cues available to surgeons intraoperatively. Example, palpating a semi-solid ground glass opacity can be challenging even with an open approach, particularly in a patient with interstitial lung disease. By the use of intraoperative imaging, example, microcoil placement with intraoperative fluoroscopy can allow visual rather than tactile localization. So, you don't have an uncertainty there. Likewise, missed palpable nodal disease may be less important in the age of high resolution preoperative computed CT and PET CT scan. Nodal resection is largely visual, but port selection could be suboptimal for accessing mediastinal nodal bases. MIS surgeons have addressed this problem by developing alternate approaches for MIS with anatomical equivalence. Potentially new technology. So things are becoming, the technologies are making our life a little better. So development of image-guided surgery, particularly relevant in the context of growing numbers of patients presenting with smaller peripheral nodules identified on screening CT, are extremely challenging to localize. If you're going to perform a sublobar resection, nodule localization is the single most important thing. Platforms are employing three-dimensional imaging and fluorescence guidance as being evaluated for integration into surgical navigation system, which means that you have multiple things which are being done at the same time. You have your CT scan, your MRI scan, your bronchoscopy finding, and your radiooptic isotope. All the things are being integrated into your image to give you a three-dimensional idea of localization of that particular tumor. Now, and this is also being done on real time. So hybrid operating rooms for procedural areas are being designed to allow routine intraoperative imaging whose results can be fed back directly to the surgeon. Through those special glasses, you can actually have a clear idea. And this is almost like all those sci-fi movies that what you're seeing. So these are guided therapeutic operating rooms for evaluating new technology related to surgical guidance. There is none like this in India, but it's just a matter of time before it really starts. Now, they will have key features which include dedicated engineering support staff, increased space to accommodate larger teams and devices, and integration of relevant devices within the OR to facilitate clinical workflow. Devices will include a real-time dual energy CT scanner, a robotic cone beam CT, CBCT, C-arm, endobronchial ultrasound system, and fluorescence endoscopes. So when you combine the images of all this, then everything will fall in place. The robotic cone beam CT scanners adapted imaging small tumors and other surgical targets are easily able to generate 3D reconstruction of on-table real-time images being integrated within the navigation system to provide literally like a GPS guidance to surgeons. You can actually go to the spot and then stop. And you know that you have to have equal amount of normal tissue all around. You have vascular guidelines. You know which vessel is sitting where. So you can actually take out all that is really required and leave everything behind, which is not really required. The CBCT can be used to generate augmented reality during pulmonary resection to confirm appropriate resection margins while saving all the vessels. So a reconstructed three-dimensional image over real-time video image is really a great kind of a help. Artificial intelligence is being integrated now with broad potential uses like real-time image analysis to identify critical structure and possible target locations directly from thoracoscopic image. The special use of this particular thing is for the artificial intelligence will continue carrying this memory for the future so that training of the juniors become very, very straightforward. It enables automated robotic surgery. The robo may be able to function as a surgical assist, typically repositioning the camera and assisting with operative site exposure. For example, you have a lesion in the right upper lobe, which is deep inside, and with a few vessels around it, the robo can actually analyze which is the best angle for the camera and which is best the line of excision. It can mark on that particular lung, and you will be able to take out only that particular part using your staplers. It's just a matter of time before the robo actually start doing that particular surgery, and I'm sure the scientists are on it. So machine learning could enable AI to duplicate patterns performed by surgeons, so preventing the risk of human error. If there was a difficult kind of a situation, how has the previous expert surgeon bypassed that particular risk and completed that that particular surgery? The robo will definitely remember that, and it will use that wisdom to actually train the next person. This combination of AI navigation and pattern replication might allow a potential autopilot system that stops automatically as the dissecting instruments vessel is in its way. It will stop that particular dissecting instruments altogether. To this end, the surgeons, engineers, and scientists continue to cooperate in developing more effective solutions. So this is where we are going. So where are we finally going in minimally invasive surgery? This is a continuously evolving field in two directions. The first is ongoing work in reducing the size and number of incisions, like uniportal VATS, or alternatively in relocating the incision to an area that causes less postoperative pain, like subxiphoid or subcos. The hypothetical advantage of uniportal over multiple ports includes improved postoperative pain control and shortened recovery time. Large data supporting or refuting this hypothesis will likely become available over the coming years and will be necessary to justify the expected increased technical difficulty associated with uniportal approaches. The second direction is increasing the use of robotic surgery. Costs, of course, remain a consideration. Although the number of ports needed for rats may be the same or greater than standard wards, the stereoscopic vision and wristed instruments enabled by rats may lower the barrier to MIS adopted by surgeons currently performing open procedures. Further, it may allow more complex cases to be amenable to MIS that would otherwise require an open procedure. Randomized data analysis has shown all this. So, dear friends, mind you, MIS is here to stay. So, if you have not already got the hold of it, please learn it. In next 10 years, almost all the surgeons, thoracic surgeons, will be experts in MIS. Today, it is not possible to offer your care to a patient of gallstones saying that I will do open surgery. The person is going to go away from it. Same thing will happen in case of thorax. So, MIS is the way, and robotic will be almost be the standard thing in almost about 80 to 85% of the patients over a period of time to come. Thank you.